request Dr. Surajit Giri to come up, please.
Respected chairperson present in the dais and ladies and gentlemen present here. So my topic is regional nerve block at elbow for close reduction of distal fracture as an outdoor procedure, and we have taken 500 patients, and it is purely an observation, our observation only. So this is a very common fracture, especially the elderly people, and these are most of the time these are managed by closely. They do not go for operative procedures in our setup, but they go for the operative procedure also, but most commonly close manipulation. And there are a lot of available techniques are there, from hematoma block, the Beers block, the axillary plexus block, or nerve specific block, or simple general anesthetics. But what has all of the techniques have these are advantages and disadvantages. But if you go the axillary plexus block for this simple close reduction manipulation of distal adducer, it will be overkill for the patient. It will paralyze whole of the limb, which we do not want. So what we tried to see, our aim was to determine the efficacy of median and radial nerve block in distal adducer fracture at the level of the elbow, just two nerve. So we have taken 500 number of the patient from February 2010 to February 2013. And all distal adducer fractures coming in this period are included for close reduction, but associated ulnar fracture age less than 20 years and refusal of the patients were excluded from the study. Now if you go to the demographic profile, you see almost most of the patients are elderly, and there is a female predominance is there, and oral intake is not a contraindication for these procedures, and the 64% having coexisting medical illness, COPDs, diabetes, like that, and few of the patient has multiple fracture and bilateral distal adducer fracture, and one of the this patient I presented in first era also as a poster. Now as we are from a very small setup as well as a very small community, we do not have hospital ethical committee, so we have taken permission from the hospital superintendent, and the blocks were performed in the operative room, and with a good IV access, with standard monitoring. The drugs are used, the 0.25% bupivacaine and 6 ml per nerve was used for median as well as for the radial, and it was a PNS guided block. Now blocks are assessed as 30 minutes by pressing the distal radius. If the patient complained pain, it was called failure of the block, and they are supplemented with 1% lignocaine with adrenaline 15 ml. None of the cases required other anesthetic techniques, and the patient surgeons were given feedback form at the end of the procedure, and they were discharged immediately with advice. So what we follow in our setup and in this technique, we look for the flexion of the finger and extension of the finger or the thumb for radial nerve, or the flexion of the finger for median nerve. And the patient position, the hands are pronated, supinated, sorry. And the landmarks are the elbow crease, and this is the biceps tendon. We go 2.5 cm lateral and 2.5 cm above for the radial nerve stimulation, and for the median nerve, the brachial artery is palpated, and just medially we insert a needle for median nerve. And we put the local anesthetics at 0.4 milliamperes, where we are getting this desired contraction. We give the local anesthetic after repeated aspirations. Now what we have found at a 30 minutes, we found that 79% of the patient have no pain at all, but 21% of the patient group. Now block was assessed as 30 minutes, and we have found that 98 to 99% they fail to flex the fingers or extend the fingers, but the clinical anesthesia was found 30 minutes in 79% of the patient, but the 4% of the patient required another few minutes extra, because this patient we have to go for axillary brachial fracture, so it took some time. Now then the patient rated this on an excellent technique. There is 61% rated this on an excellent technique, but 4% they feel that giving this taking multiple injection, it is not good enough for them. But surgeon feel that 12% with the patient there is an inadequate relaxation, otherwise it was okay for them also. Now we tried to find out the hospital entry to the discharge time. The patient came to the hospital, they go for the x-rays, the orthopedic consultation, they go to the OT, they get the block, and they discharge at 3 hours in most of the patient. That is in 88% of the patient. It is a purely outdoor technique. Now they were asked whether they will take this type of technique if near future, if will get this distal adducer fracture, and 92% said yes, they will take this type of technique. Means it is quite acceptable to the patient also. Now, what about this 21%? Why there is pain? And we have found that the 14% of the patient has intra-articular fracture, 5% has grossly displaced and unstable fracture, and 2% has, 2% has more than 48 hours of duration of the fracture. Now, this is a purely distalated fracture with no intra-articular surface involvement. This is extra-articular fracture. If you give the median and radial nerve block, patient will not complain here. But whenever the articular surface involves, probably these areas, the articular branches comes not only from the radial, median, but also from the median ulnar nerve. Also, maybe ulnar nerve may be required for this type of fractures. Now, what the anatomy says? Now, anatomy, this is the good study. This is a cadaveric study, and they have shown that the distal radius area, these are supplied mostly by the posterior interstitial nerve from the radial nerve, and the anterior interstitial nerve from the median nerve. So these are the two main nerves supplying the distal radius area. But they have also concluded the complete innervation of the distal radius has yet to be determined. There is a lot of crisscrossers there in the distal this joint. Now, what the literature says about the anesthesia. Now, this is one of the great Cochrane database review. There is anesthesia for treating distal radius fracture in adult, and they have taken all the studies. There is hematoma block, the axillary black block, nerve blocks. They have taken all the studies, and they found there was insufficient robust evidence from the randomized trial. But I have also gone all the studies, and I found there is no mention about the fracture type, whether it is intra-articular or extra-articular, or what is the duration of the fracture, 48 hours, 72 hours, or displacement, what is a minimal displacement, gross displacement, and these are the main, maybe the determinant factor of the pain in nerve block group. Now, we are from a very small community, and here the people are very poor, and they have they do not come to the hospital if there is a distal radius fracture. Seems it is a very simple fracture, and they go to the village treatment. There is a herbal is there, they put the herbals and go for works and like that. So they do not come to the hospital, even to the government setup also, because this is a major reason is the cost factor. It's a high cost to the private setup as well as to the some cost they have to apply for the government hospital also, and they have to wait to the government hospital also because of the more patients in the government hospital. Now, our technique is a very simple technique. It is a safe technique, and it is an outdoor basis technique, and the cost to the patient comes around suppose 2,000 bucks only. So day by day the patients increasing to our hospital for close manipulation from 2010 to 2013 it is day by day increase. So it has a social impact in our community. So we are able to take the patient to the hospital by this our technique. This is a simple technique. So to conclude, if it is extra-articular, if it is a minimally displaced and less than 48 hours of duration fracture, we can go this type of anesthesia. There is PNS, gutters, radial and median nerve block. Thank you, sir.
For the patients who have some pain, are you referring to pain at rest or pain with manipulation?
No, sir. After 30 minutes, I assess the block with pressing about the distal radius. And if they complain the pain, this is the failure group, and then I directly go to the axillary group.
So you, the operator, perform the assessment?
Yes, sir.
Are there other drugs given during the reduction procedure?
No, sir. No, no. The only blocks, and if the blocks fail, I go for the axillary.
And the purpose of this study is, do you think the distal block is safer than other brachial plexus block? That's the first.
Yes, it seems to be safer, and also it does not paralyze the whole limb. And most of the time these patients are they come on an outdoor basis. They have taken foods and all, they got fractured and they come to the hospital. So they have to wait for 6 hours or 7 hours for this axillary brachial plexus block. So why not better to go for this distal blocks? So
how many of your patients have to have an axillary block as a rescue?
69% I have got by distal radius, median and radial. And 21% I got the axillary plexus. Yes, sir. Thank you, sir.
What was the duration of the pain relief?
So, madam, immediately after the patient was discharged, so we do not know about the duration of the pain relief. They go home directly, sir.
Thank you.
Thank you, sir.